Fired you at one point, but now you're here.
Welcome back
so
to the
welcome
flock,
back.
Jeremy.
Yeah.
Hold on one second. Louis, I've got to excuse myself.
Okay.
I've got to go.
Gotta go.
Go run a business.
All right, man. Thank you very much.
Yeah, I gotta go.
We'll see you.
Jeremy Faust is on the call here now from. Well, your phone number caught me off guard. I thought you were a telemarketer at first, so I have to apologize. So, how are you doing?
I'm doing fine. I'm trying to catch up on what's going on in my part of the world, which is a new variant. So learning a lot and kind of burning the midnight oil to keep up and talk to my friends here in the United States and also around the world, and try to sort out what everything really means.
So Dr. Faust works at Brigham and Women's Hospital at Harvard and in Boston, and you've written extensively through the Bulletin program, which the Lead is a part of, about what's going on. Tell us what you know about Omicron right now. What is it? What is it you're kind of paying attention to? And is there reason to be concerned? There's been some suggestion that it's not as serious as maybe Delta, but what are you hearing?
Yeah, I mean, I'm definitely concerned about this. I mean, I think that this is a pretty unstable kind of situation where we don't know everything that we need to know to be able to say, okay, false alarm or not false alarm. I think it's early, and I think that I've heard some things in the past day that kind of catch my eye, and things I didn't want to hear. But and I'll tell you about some of that stuff. But I think the main thing is that this started because a genetic analysis of the variant was done. That is that the scientists look at the sequence, the genetic sequence, and they're able to say, look, that's kind of that sequence has meaning to us. We think we see how many changes and mutations there are to that genetic sequence. That tells me maybe this is a scary variant. But the reality is, Louis, that we actually don't have the technology to make that leap to say, okay, wait, if this changes in the instruction manual of the virus, that means this behavior will result. And so we don't really have that technology, but we do sort of have hints of that technology and that ability. So I think we're scared that we read the information and we see, well, this could be more contagious, this could evade our vaccines, but we don't know that. But what's happening now is we're beginning to hear that it is very contagious. But the question is, in terms of the vaccine holding up and in terms of severe illness, do we have anything to worry about? In terms of severe illness, I really haven't heard anything yet that bothers me. But in terms of the contagious piece, I am beginning to hear that there's quite a lot of contagion.
One of the things that was I read yesterday was that the suggestion that this came out of possibly the fact that in South Africa that HIV is very hard to control or treat, and that the person that this may have happened to was immune compromised. What is your understanding of how that works exactly?
Yeah, that's a great question. And I think that for one thing, I'm not certain that we really know that it came from South Africa. Mm-hmm. I think we know that's where it's kind of broke out.
Right.
But I think that so wherever this happened, though, it has this version of the coronavirus has so many mutations that it feels like that it's almost like time has been accelerated. The way I think about this is like, let's say you lost your cat and it's been an hour, but then your cat shows up 20 miles away. You're thinking, wait, how did my cat get 20 miles away in just 1 hour? And so that's kind of what we're looking at here. It's like, wait, how did this variant show up with this many mutations in such a short amount of time? And one explanation for that is that this particular virus, was in one person's body for a long time, and that person was immune compromised, and that they might have received various treatments like convalescent plasma or other treatments that can actually, when they don't work, can actually kind of backfire and cause the virus to sort of get smart and mutate and avoid all that stuff. I don't want people to think that's a common thing. I think that's a problem that would only happen for a patient who basically has almost no immune system left.
Right.
We're talking about people who, kind of the proverbial bubble boy, literally have to be on immune suppressing medications, and that's the level that this can happen at. Not like you or me if we got some treatments or a vaccine. So that's the thought, is that maybe this virus lived in one body for a long time and had kind of a chance to evolve in that kind of pressured environment.
You've also written extensively about Texas and that this was one of the leading causes of death among younger people. Tell me a little bit about that study as well, because here in Texas, there is I would say a high level of deniability, or denial about the I guess the virulence of this disease. What has been the feedback on that paper, and tell me a little bit more about it too.
Yeah, so this is a research paper that I led a team of researchers here at Harvard, and then a bunch of folks at Yale as well. So, and we've been looking at mortality or fatalities in young adults, 25 to 44, so age 25 to 44. And I got into this kind of a year and a half ago, really because I couldn't believe it would possibly be true. I sort of was buying into the same thing that many of us were saying, which is, look, this is mostly a disease that kills old people. Mm-hmm. And that's certainly true. It has, the numbers add up. But the thing is, young people, just for all reasons, 25 to 44, that age group, the death rate in general is so much lower, right?
Right.
And so if you had a doubling of that group, it would take a long time to notice it, because you'd kind of just have to see so many cases. So we wanted to actually make sure that we weren't weren't wrong. So we started to look into it, and I was shocked. I was just shocked when I realized that when there's a really big outbreak in any kind of jurisdiction, a city or a state or a country, and it's uncontrolled, the young adults get hit hard. It takes enough cases. But when there are enough cases, literally COVID-19 can become the leading cause of death for adults 25 to 44. Wow. We certainly saw that in Texas for the third quarter of 2020, and for all of 2020 in the Hispanic population. So we know that the Hispanic population is very frequently having people who can't necessarily do a shutdown, right? They have to go to work anyway. They're exposed. They don't necessarily have as much access to primary care. So it's really unfortunate that we saw that play out. And I suspect that the same kind of thing will have played out nationally. I think we'll know that literally in the next coming days. We're going to get a really nice full readout on the entire country from the CDC from last year. They're going to give us really detailed, granular data, and so we'll know that that unfortunately this has probably happened elsewhere as well.
We had the fire chief here on in Kerrville, and just so you know some of our numbers, we're actually being told as of yesterday that we had 500 active cases. Kerr County is about 50,000 people here in kind of, I guess, central West Texas. And we've had, by my count, 200 fatalities since the start of this thing. But the fire chief was on the other day, and he had it, and he's 51 years old. He talked about how miserable it was, but his concern was long COVID. What do you hear about long COVID, and what should people know about that?
Yeah, long COVID is incredibly important story to keep watching develop. One of the things with long COVID is, I think that we are still learning how to define it. We don't even really know what we mean when we say long COVID. Mm-hmm. And that's actually really important, because there can be different forms, there can be different meanings. So one of the distinctions that I have not seen made nearly enough is the distinction between what I would call medium COVID and long COVID. So medium COVID would be something like, 2 to 6 months after this virus, you are still feeling symptoms, or you have new symptoms that might be related to your previous infection. And in a way, I actually think that medium COVID is something that probably happens with almost any serious virus, that, medium flu, medium RSV, medium anything, right? Mm-hmm. And I think that our body is just, literally, it was a war zone. And it's sort of the equivalent of biological shrapnel. Like, your body just is responding to that. And I think it's very common. I think that SARS-CoV-2, it's just coronavirus, does this at pretty high rates, we've learned, right? Then there's long COVID, which is sort of maybe 6 months, a year, and now we're coming in on 2 years. People could have longer term symptoms, and I think those examples are going to be less frequent. And I think that the the research there is going to be very, very focused on what are the symptoms that actually really do persist for this long, because we've heard of hundreds of symptoms, and they can't really all be they can't be all really part of the story. Probably some of them are, and then some of it's probably just something else. We don't know. It could be unrelated, or it could be that they have another diagnostic condition that we don't know about. And then, of course, there's the stress of this whole thing, right? I mean, like, this is a very stressful thing. People, the body responds to stress in very impressive ways. There's actually something called broken heart syndrome, which is unrelated to all of this. But, like, literally, if someone has an emotional event, their heart literally goes under stress. And we see that on an ultrasound, and we see that on an electrocardiogram, and that particular version of it is usually benign, but it can be dangerous. So we know that the stress of this can cause physical manifestations, and so I kind of wonder also to what extent some of the things we're hearing about is a combination of these things. So I think we're learning a lot. But I think, patients have really alerted us to this, and researchers are doing the right thing, which is to start to study it more. And most importantly, figuring out, do the vaccines prevent it? Do other therapeutics help it? My suspicion, and I think the data show this, is that the vaccines do indeed decrease the likelihood
of keeping that long COVID and reducing the severity of the illness, correct?
That's correct. I mean, I think clearly the vaccine is still holding up for protecting against severe illness, hospitalization, and death. And I think there's some suggestion in some research that it prevents long COVID. We even heard in the initial vaccine rollout that people who had long COVID, who then got vaccinated, felt a change in their symptoms for the better. I don't think that's been verified. All to say, we have a lot to learn.
Yeah. Just two more questions for you. One from one of our viewers asking, are we ever going to see an end to these variants? Is this just going to be on and on and on and on, or how is that going to work?
My opinion is that we are going to always have these variants popping up. So that's sort of a new normal. But what I do want to say that it's a little more positive, because that sounds really depressing, is that I think we're going to get better and better at understanding what they mean each time around. So we've never really had an opportunity to study a virus this carefully, this closely, this quickly, and with the entire science community, the entire world's community of experts sharing information in real time with the best technology that we have. I think we're going to learn about the thing that I said before, which is when we look at a bunch of mutations, or when we hear about something new and we have only a certain amount of information, but we don't yet have a month or two of clinical data, right? Can we make that leap and say, here's what we think we know this means? And right now, I think we're kind of in the minor leagues with that, although, of course, compared to our predecessors, we are, giants, right? I mean, They couldn't do any of this 150 years ago, but I think that we are still learning. And so I think that we're going to have these new variants. And I think that as time goes on, we'll get better and better at knowing what they mean sooner, so that they don't have to be disruptive unless they're really problematic. And I continue to think that Omicron is in that moment where we don't know. I'm worried about it, but I don't think we yet know.
What is it like to be, you work in emergency medicine, but what is it like in the hospitals for healthcare workers who are dealing with these COVID patients? We had at one point, our hospital here has a 14-bed ICU. It was pretty much full during September in particular. They had as many as 48 patients in the hospital of a hospital that is designed to hold about 86 acute care patients. So you had times there was more than half of the patients with COVID. What is that like on a staff?
Well, thanks for asking that question, because I think sometimes the sort of like healthcare hero thing is like, it's nice, but it goes to the wayside, or people don't understand what it is we're dealing with. And so I appreciate it. And I think that, one thing I'll say is I think that when we're seeing COVID and we're not overwhelmed, and that's really what I'm dealing with right now. I'm in a very highly vaccinated area. When we're seeing COVID, but we're not overwhelmed, I think there's still that same level of commitment and professionalism that you'd come to expect. And I think that we're proud to go to work and do this. And it's, we'd rather be dealing with a virus that was a little less scary, but that's okay. We signed up to do things like that. I think that people in my profession, the doctors, the nurses, the technicians, the PAs. I think the burnout and the difficulty and the emotional kind of overwhelming sensation comes when it feels like a tidal wave and it's just never ending.
Yeah.
And that has happened in so many places, and I think you're describing that we're, it's like getting on a plane and the pilot thinks it's not safe to fly. Well, we have to fly and we don't have a choice. And so I think in those situations, we're asking people to make sacrifices and say, look, do whatever you can to slow this virus down. Do whatever you can to stay out of the hospital, the ICU. We can only do our job if we have the resources. And there literally are moments, we've had moments where people have had those situations that we feared, right, where there's just not enough beds or not enough ventilators. And unfortunately, that's a reality. It doesn't happen as much because I think we have done a decent job at slowing this down in some ways. But honestly, there have been places and times where we didn't achieve that, and that's a tragedy. It's totally avoidable. But I think ultimately, I think if the public knew what it looks like in an ICU when this virus is let to roam free, I think that they would have second thoughts.
Yeah. Hey, Dr. Jeremy Faust of Brigham and Women's Hospital at Harvard University. Thank you so much. You can follow him on insidemedicine.bulletin.com. A great read, and I try to link to as much of your stuff as I possibly can. And it's great to have you as a resource, and I appreciate you taking the time to talk to us today.
Yeah, no, thank you. And I mean, Texas is really an epicenter, and I know you guys are, having an interesting and rough period. So I appreciate your coverage.
All right. Well, thank you very much, Dr. Faust. All right. Appreciate it. All right. Well, that was Dr. Jeremy Faust. And did you guys learn anything?